And certainly this topic is a place that I have spent a lot of time researching and thinking clinically, but I understand that when we're talking about these types of challenges with living with concussion, often we're coming to these conversations with lived experiences. And you may or may not be here for yourself. You may be here for a family member, a friend. And I thank you for being here, because learning more about concussion, I think, is a really quite an important thing. So I do work as a clinical neuropsychologist. So what that means is a type of psychologist who really focuses on trying to understand brain and behavior relationships, and always kind of thinking brain first. And so you'll see that the discussion today is very much focused on, if we can understand our brains better, regardless of what we're going through, I think we come out more informed and more able to kind of pull the right levers to kind of head in the direction we want to go. So that's my hope today, in trying to build a life, living and learning with concussive injuries here. So in terms of conflicts of interest, I don't have any disclosures today, not being funded by any sort of particular agency or pharmaceutical company or something to sort of pitch any specific information. The opinions here of this literature and this research, some of this research comes from our own research lab at Brock University, as well as looking at the literature more largely. But these opinions are my opinions on the literature, and you will certainly hear different opinions around some of these topics, and that's perfectly okay. We can certainly talk about some of these things, which I think are really quite interesting in themselves. Essentially, the goal is for today is that this presentation will have two components. The first component, as we talked about, will be you listening to me and hearing a little bit about a bit of an update on some of the literature. And then I'm hoping that we can, have a kind of more open conversation at the end around questions about the presentation, but also just questions that anyone has around this sort of experience or specific challenges. I know that sometimes it's difficult to get questions answered, and I'm hoping that perhaps is an opportunity to do so. And so with respect to that latter part, we'll hold questions till the end, and then at that latter part, we'll sort of turn the video off, and we can have an opportunity to have a conversation. And I think it's really important that what stays in that conversation, particularly around people's lived experiences. So if someone does feel comfortable to share a little bit about their lived experience, that it be important that it stays within this environment in order to remain safe and confidential. My main goals here are about really focusing on educating around maximizing recovery after living with the effects of concussion. So how can we go about this in a way that really can permit us to have the best recovery possible, right? And that may be for someone who's just had a concussion maybe a couple of weeks ago versus the person who's had a concussion several years ago and really still struggling with symptoms here. I want to set realistic expectations around the recovery process and addressing any myths regarding concussion. There's a lot of opinion out there. There's a lot of conflicting medical opinions around this as well. So you're definitely going to hear, depending on who you ask, different perspectives on kind of what people think about concussion and what we expect around recovery and what does recovery mean. And see, if you're feeling confused, you're certainly not alone. And certainly the medical and professional community has a lot of sort of differing perspectives on it. And my hope is to capture a little bit of that, but also to point, some directions, the perspectives that myself and many of my colleagues in neuropsychology tend to share. And my ultimate goal, if you can leave with nothing else, is to provide hope around those living with the effects of concussion, whether that be sort of having recently sustained a concussion or living with the more long-term effects of these types of injuries. So to kind of start the conversation off, talking a little bit about what the definition of concussion is. And so we know that this is kind of any kind of transient change to our brain function that results as a matter of sort of forces applied to the brain through biomechanical force. So if I have a fall, for example, or if I'm in a sports related injury, or if I'm in a motor vehicle collision, for example, all of these are sources of it. And we certainly know that depending on our age, we're more likely to sustain certain types of injuries. So for example, when I'm a child or, early adolescent, most of my injuries may come from things like falls or things like sports related injuries, right? And as I get older, they may come from more motor vehicle related sort of experiences. And then as I age, into thinking about things like retirement, the source of concussion injuries tends to again change back to things like falls and things like that. And so when we think about the criteria around this, so the criteria around concussion has recently been updated after quite some time. So initially the guidelines around concussion put out by the American Congress of Rehab Science really had published this out in kind of the early 90s, and they've recently updated, sort of these guideline papers around how do we define this? Can we start to be more consistent around this language? And there are some subtle changes that are meaningful to clinicians, but ultimately, I think the specifics of the change are not as massive as they could have potentially been. And I think one thing that's really great is that they've continued to open the definition around concussion to include that we don't have to have this sort of immediate medical evidence surrounding it. I think the worry that a lot of us as clinicians had was that this idea that you had to have immediate medical documentation around concussion injuries. And as we know that many people don't have the opportunity to have immediate medical access, or it just isn't at the forefront of their mind, nor can it be sometimes at the forefront of the medical system. So sometimes people are in, for example, motor vehicle collisions where the focus becomes other parts of the body for medical reasons, and the focus isn't the brain, because sometimes the brain doesn't display its symptoms as kind of immediately as some of the other systems in our body. So ultimately, when we talk about concussion, we're talking about a hit to the head through biomechanical force. And this could include things like blast injuries that are sustained in combat, but all that result in some sort of alteration in consciousness. And certainly if there is a loss of consciousness, although this is not required, that would certainly fit this. So many people describe seeing stars or being dazed or feeling like my cognition, my sort of neurological status has been disrupted, and this sort of alteration in sort of mental status occurs immediately following the injury. It's not something that necessarily people see, days later. There's this delay in between, and that sometimes individuals will experience changes to their memory. So either, memory for events that happened before the injury or immediately after. And we often refer to this as post-traumatic amnesia, and we try to measure this or estimate this. And it's actually quite a challenging thing to do because, of course, if someone has a loss of consciousness and memory disruption, it's hard to figure out where one begins and where the other, kind of ends. And the challenge will be, of course, is the person may not always know because their memory may have been disrupted for that process. And if this was not a witnessed experience, then it's quite challenging. And of course, other things like other neurological signs and symptoms. Some people, for example, may experience balance or gait disturbances, seizures, or these types of experiences, sort of transient changes. So these acute, sudden onset neurological changes that happen again as a result of this sort of injury. So what is concussion really? So I like to show this sort of picture on the right hand, although I won't have it play too long because I know it can sometimes be disruptive for our visual system. But essentially it's this idea that within a concussion injury, these sort of forces applied to our body and neck and head then result in sort of this back and forth motion that we tend to refer to as coup counter coup related injuries. And these can produce sort of as a result of linear force, so forces that are linear direction versus sort of twisting motion. So for example, an athlete who's running and runs into someone else or into and has linear forces, they're straight forces applied to them, versus someone who is hit from the side, for example. And what we know from the literature and from the research that has been done is that certainly linear forces are never good, but rotational forces seem to produce even more challenges. And so we can see this type of injury as both a mechanical injury. So the mechanical injury results directly from the forces that are applied, and that may be linear, so straight, and that back and forth that you kind of saw in that video, and it then stretches the neurons, and some of those neurons become temporarily disrupted, and some neurons, depending on the injuries they sustain, may actually die as a result of that stretching process. And sometimes we call that diffuse axonal injury. So this idea of stretching and injuring the axon, so the kind of lengthy matter that actually connects cells together so that they can kind of communicate with one another. And the second piece to concussion injuries, so the mechanical injury is the first piece. The second piece is the biochemical injury that results as a result of this injury. And so we often are thinking about the former, and rarely are we kind of thinking about the latter as much. So what kind of biochemical changes happen? So when we disrupt the brain, what kind of chemistry is released as a result of that? And this is a very complicated picture that sort of highlights the extensive amount of work that's been done to map this sort of pattern out. But the short of the story goes essentially that when we sustain this mechanical injury, that a huge release of excitatory chemicals in our brain, we often call them neurotransmitters, are released. And this happens at a time when the brain is in an energy crisis. And essentially, so when we sustain an injury, we have reductions in blood flow, and we have, cells that have been, impacted by this injury. And so they're not, the sort of power plants of the cells called mitochondria are not performing at their peak. And so at that very same time, when we have an energy crisis, the brain is then being told, hey, rev up as fast as you can. Like all of this chemistry is sort of being released and told, like, run this system as hard. And it's kind of like, not, filling the gas tank while hitting the gas in your car. And so essentially, it's not just the physical mechanical injury that's sustained. Further injury to the system results from that biochemical changes that happen. And a lot of research has worked to explore, the mechanical injury is hard enough on the system. Can we slow or interrupt that biochemical process? And so things like hypothermia, so using temperature, for example, can we slow that process down? Like if we know that temperature tends to reduce activation of the system, does that have an effect? And the answer, unfortunately, seems to be not in concussion injuries at this point. We don't have good evidence for that. Certainly with very young pediatric injuries or with stroke-related injuries, there's been evidence for this, but we've not been able to replicate that in concussion injuries yet. And I'm not sure we know why that's happening at this point, but we haven't been able to figure that out. We do know that the opposite is true. So there's evidence to say that if you sustain your concussion under higher temperatures, so if you happen to be playing football, for example, in a southern, state in the United States, and the temperature is very high, it does appear that actually can worsen an individual's injury compared to someone, the temperature in which they sustained the injury was cooler, for example. So we do know the opposite is true, is that, being dehydrated, being being very warm in the day does seem to have an effect on that system. And there's some really quite interesting but challenging research to tease apart that has really shown some evidence around the temperature that the person is in can also sort of modulate some of the injury effects themselves. So one of the challenges that comes as a result of concussion-related injuries is that each person's injury is quite different. And this is true in brain injury at large, right? So, we're talking about mild injuries. So mild not meaning significant, but in terms of severity of injury, we kind of classify this based on sort of these indicators that tell us where things kind of fall. And so we'll talk about things like moderate and severe brain injury. These don't necessarily refer to the types of severity of symptoms. They refer to the sort of neural injury indicators that happen at the time of the injury. So how long was the loss of consciousness? How long was the loss of memory challenges? Are there, neuroimaging findings that correspond to this? All of those things are utilized in the classification of injury. And regardless if you've sustained a severe traumatic brain injury or a mild, the type of injury, every person's injury is quite different. I've never met anyone with exactly the same type of injury. So each person I meet that's sustained a traumatic brain injury of some form has a very different injury. And I think that's posed a lot of problems for us in research and in clinical practice. And I suspect that's also led many people to feel invalidated by the process, because it does mean that each person's experience can be quite different. And if you clinicians like a bit of a textbook to say, like, this is what you do with each person that sustained an injury, and unfortunately it's not as clear as that. So we know that there's a whole bunch of symptoms that a person can experience following an injury, and we classify them into sort of physical symptoms. And these things could include things like headache, changes to our, vestibular system. So dizziness, balance, nausea, fatigue, all these sort of things, changes to sleep. Many people will experience, sensitivity to sound, sensitivity to light. Some people will experience, things like seizures or numbness or tingling, pain associated with things around things like their neck. So it's not just the brain that can be impacted. Of course, there are musculoskeletal effects of these injuries as well. We can then compare and contrast these to experiences that occur in the cognitive domain. So things like feeling a sense of, brain fog that's described. So feeling kind of just this lack of clarity in thought and kind of the, ease and fluency of our thoughts. Difficulty being able to pay attention and really sustain and focus our attention. The speed in which one can think, so how quickly can one sort of process information. Troubles kind of thinking clearly, finding words. So some individuals will describe just, I know the word I want to describe, I just can't seem to find it all the time as easily. Some people will describe difficulties with making decisions, feeling like I'm often making the wrong decision after the fact. I just can't seem to kind of head in the right direction always. I struggle maybe with planning and organization of my thinking and my behavior. I feel disorganized. I feel like I can't manage organizational demands. And then we can think about the last category of behavioral and psychological symptoms. So things like how, behaviorally, do I have challenges with regulating kind of my impulses? I feel like I am making riskier decisions, or I'm acting out in ways that I didn't see myself do in the past. Maybe my expression of emotion is different for some individuals. They feel like they're more irritable and agitated and sometimes feeling aggressive. Psychologically feeling, changes in their mood, anxiety, depression, and changes with how they approach kind of sleep, and this sort of psychological approach to feeling like I I can't get enough sleep, or I can't get into sleep easily, and then feeling very fatigued throughout the day. So brain injury of any kind is very complicated. And I think that's what's made this really hard to study and to be helpful around clinically, is that we know that there are many complex symptoms. These symptoms interact with one another. So, if I'm struggling with my planning and organization, maybe I can't, get my meals prepared, and then I'm not eating regularly. So then I'm having more and more challenges with fatigue on top of what I was already feeling. So you can see how these sort of experiences can stack up on one another and make things particularly challenging. And this idea of like subtle changes to our system, as if that means that, well, they're not that big of a deal, is a real misnomer. Mild does not necessarily mean minor problems, right? It just means that relative to the severity of injuries that one can sustain, there's still a lot of really great neural tissue doing exactly what it should be. But, sometimes these systems are getting in the way of one another. And so these will, interact with our pre-injury sort of experiences. So, if someone has going into an injury is already struggling with their sleep, for example, that may make it particularly hard to recover from an injury, given that much of the brain recovery process is actually going to occur during sleep. And we'll talk about that in more detail. What if someone went into an injury having felt particularly anxious or depressed, or had been dealing with tremendous life stressors, or had experienced psychological trauma of some kind? All of those things will make the recovery process different and perhaps more challenging to navigate. And sometimes there's this tendency in our field to try to like simplify things and say, well, it's either, it's all the injury, or it's, not the injury at all. It has everything to do with before the injury. And the reality in the research is that these things, of course, interact, right? Brains are complicated, so of course answers become complicated. And these things become complicated additionally after the fact. So what kind of supports does the person have afterwards? How accepting or acknowledging is the environment around them? So these what are called post-injury sort of, factors that are related to it. So is a person kind of walking into a very understanding, work or occupational setting that's going to permit, for example, opportunity to rest and recover and sort of take time away without feeling guilty for doing so? Or is the environment particularly challenging to navigate? And in fact, it's actually very difficult to take time off. We see changes, for example, in the university environments. At one point, university did not really recognize concussion injuries as a reason to take time away. And now you see sort of regulation in universities changing so that sustaining a concussion immediately results in sort of time away from the classroom. And this is an opportunity for rest and recover, and to slowly, gradually build up cognitive stimulation and exercise, but to do so in this very kind of gradual fashion. And if we don't have that time, we know that we can make the recovery process more challenging. And certainly the literature says that if we permit that time, outcomes tend to be better. And so it really does matter what you're facing after the injury, is not just the injury by itself. And you can see how pre-injury, the injury itself, and then post-injury interact to produce very complex outcomes. And often, unfortunately, insurance providers will often try to sort of tease these things apart. And it's very, very challenging to kind of pull them apart and understand them. But clearly, it's not as simple as saying it's one or the other. These interaction effects need to be understood. And I think more and more being understood in research, but that's not always happening in clinical practice. So we really recommend thinking about, building a team around, concussion. And when someone sustains concussion, no single clinician has sort of the expertise to really navigate all of the features, right? And so building a team in some, cities and environments, there are actual teams that are kind of clustered together to work together, because we know that no one has all of the expertise. So often we're needing some, medical, expertise on the team, and that may include things like family medicine or neurology or physiatry to kind of, be involved and contribute. Needing sometimes physical treatment. So these may be things like, physiotherapists or occupational therapists who are kind of navigating, these aspects, or vestibular kind of treatments, working on physical conditioning. And then including kind of cognitive and behavioral and emotional supports as well. And so these may include things like psychologists, clinical or neuropsychologists, or psychiatrists and social workers, and speech and language pathology, depending on kind of what's needed, and trying to kind of build this team that can help to navigate some of the symptoms. And the reality of our healthcare system is that this is not easy to access. So if you're fortunate enough to get access to a concussion clinic that has all of these experts around the table, that's one thing. Sometimes those clinics work really incredibly well, and sometimes those clinics are overwhelmed in themselves and short of resources. And if you don't have access to these clinics, which is often the case for many individuals living in Niagara, it is trying to figure out how to put a team together. And obviously that starts with one's family doctor, but some family doctors are understandably very informed about this area, and some do not live in this world as much and are, have their expertise elsewhere. And so it is trying to navigate and figure out who is going to be the best person for me. And the challenge in this is more and more, many people are saying, I can help when it comes to concussion. And it's not always clear that every recommendation and every treatment provider is equal around this. And I don't have easy or good answers for figuring out, who's the right people for your team. I do think that it matters to think about what symptoms you're trying to address, and to really want and demand sort of evidence behind the types of treatments that they're proposing, because sometimes these treatments are outside of the OHIP system and can be quite costly. And so are we receiving something that actually has some really good research behind it? And more, the challenge is not everything is evidence-based. And so can we be confident of that? And I think it's reasonable to ask, our clinicians to, explain what supports this, and really be comfortable to have that conversation to do that. And if they're not comfortable, if they don't have that time or ability, then it's fair to be skeptical if you feel that, if you have sort of a gut feeling around that. And at the same time, working to find the right people. There are, I know many clinicians in the Niagara region who are incredible clinicians. And so, have hope that you will find the right ones that fit you, and it has to be the right fit in order for this to work. So one question I get frequently is, Sean, should I have had some neuroimaging done? And if that's the case, when should that have taken place? And so I want you to understand that there are two types of scans that we can do in terms of measuring the brain. We can look at its structure. So we'll use scans that are things like, sometimes called a CAT scan or a CT scan. MRI uses a very powerful magnet, for example, to get at the structure of things. And then we have more advanced types of MRI. So for example, what's called diffusion weighted imaging or diffusion tensor imaging, which are types of approaches to MRI that can have us look at different components of the structure. And more we're having what's called DWI, diffusion weighted imaging capacity in hospital settings. Some of these more advanced techniques were almost exclusively in the research setting. The reason why some of our research MRIs are so much superior to our clinical MRIs has a lot to do with the strength of the magnet. So the stronger the magnet, the more capable the image, but they're also newer, far more expensive, far more costly to maintain and manage, and the sheer physics knowledge. Any hospital will often have a huge radiology team and a huge physics department to manage things like MRI. They're not easy things to work with. And then so we have structural imaging, and then we have things like functional imaging. So functional imaging does not tell you about what the brain looks like. It tells you what systems are doing what at any given time. And so these would be things like PET and fMRI scans, so functional MRIs, that can allow us to kind of measure like how much energy or oxygen is the brain consuming at any given time, and where is that in the system. And so in general, we tend to have access, or at least more access, to structural scans, CT and MRI, than we do things like PET and fMRI. And when we're looking at things like function, we also want to be thinking about what are we asking the person to do when we're measuring their brain. So it actually matters, and a lot of research focuses on, if I'm going to look at a functional scan, is it under resting conditions? So I just have you kind of hang out and sit in the scanner and see what happens, or do I put you under a task? And so a lot of research has focused on that last piece, where it's like, let's just focus on getting people to do different things. And does their brain do things differently than, say, a person that's never sustained a concussion? So what do we do kind of clinically? So CT scans are the most accessible. They are, fairly quick. They're inexpensive. And the truth of the matter is that when it comes to structural imaging, on average, most people will not have anything on their scan. That doesn't mean that they haven't sustained a concussion, but it's kind of like our camera is not necessarily sensitive enough to pick up on it. And so we have a rule actually made in Canada called the Canadian CT rule that actually tells doctors under what conditions they should do scanning. And sometimes it'll feel like the emerged doctor is just not being, thorough. They're not going to order a CT scan. But in fact, anytime that we expose our system to radioactive components, and CT scans do exposure to radiation, there's a cost to it. And having many CT scans increases the risk for something happening like cancer. And if you were to have tons of them, that would be problematic. And so they're always having to weigh out the costs and benefits of it. And so the Canadian CT rule actually tells doctors when they ought to or not order scans. And these would be things like under conditions of skull fracture or changes to a scale called GCS, so the Glasgow Coma Scale, or things like you've had multiple vomiting experiences post-injury right afterwards. And the main purpose of getting a CT scan is not to measure concussion, but in fact to, sort of rule out something more happening. So, if a person sustains a concussion and then we're concerned about a bleed, for example, that's sort of the reason, to use a CT scan is actually quite sensitive to picking up on blood. And so sometimes when we do scans, more often this would be MRI, we end up finding that there is something on the scan. And if that is the case, then it's no longer sort of fitting in the traditional category of just mild injuries. We're thinking that it's at least a mild complicated form of injury, or may, depending on what we find, may fall outside of the criteria of a mild injury. So having scans, at least in our clinical experience, is not always, as informative as one would think, right? And so often the camera is just not good enough to get at what we're looking at. But certainly there are more and more research protocols that are coming available for clinical practice that I think will change this with time. But the caveat is that we've been saying that for as long as I've been in this field. And so I don't know when that exact time is going to occur. Hopefully it will. Imaging would make things easier for people, I think, to understand where things are at. Seeing is believing, I think, sometimes, but there are many other ways to kind of measure these types of injuries. So what is the recovery kind of trajectory like? And I want to be careful to acknowledge that because the average does not capture everybody by any means, this may not necessarily relate to yourself or someone that you know. But what is if we take the average sort of sense of recovery, what kind of things are we likely to see? And on average, we'll see that, symptoms tend to occur quite immediately, that people will describe, that, within moments to within hours, they're noticing that things just don't feel the same, that things are feeling different. They're noticing symptoms like headache, or feeling like there's some just cloudiness in the way that they're thinking, and confusion. And the idea is that symptoms will gradually improve, and we know that the sort of trajectory is that for many people, right, that's going to, sometimes that's going to be over the course of days to weeks and into months, but that many individuals with mild injuries will recover before that 3-month mark. And what can we do to kind of optimize that recovery process? It's clear that initially we told people to rest until your symptoms are gone, and that clearly is not helpful. And some people unfortunately rested very long periods of time, and actually they felt like their symptoms got worse as a result. So there's clearly this balancing act between doing and not doing. And in general, what we want to work on is, we talked about that chemical injury that happens. And the reason why rest becomes important is that if you have a brain that is just, been through an injury and it's in an energy crisis, if you are then trying to utilize the nervous system to carry out things, you've just increased the energy demands. And so we need to provide some time for the system to, have some rest and recovery, and try to stabilize that energy sort of disruption. And so that's why we really start thinking about reducing, stimulation, how much we're doing, stimulants, as in like, right after an injury, having a huge, Red Bull or coffee is probably not the best idea, because these things clearly activate the dopamine system, and dopamine tells the system to, activate and move forward and stimulate the system. If we can work on, maximizing our deep sleep, and within that first week, we're really trying to slowly gauge, kind of gentle activities and responsibilities that do not worsen symptoms, but keep you sufficiently, moving and activated and conserving energy, and being cognizant that we can modify the environment. So we can, take more breaks. We can, reduce maybe the brightness of the light, or turn down the sound a little bit. We can give ourselves extra time, and in particular kind of some compassion around that piece, like where it's, a lot of us tend to push ourselves, and I think one thing that anyone who has had a concussion has experienced is the need to not push so hard. One idea that I think has gone around and is, become a little bit of an internet sort of meme around, is the idea of utilizing the spoons to reflect energy, sometimes called the spoon theory, and how much spoons we wake up with in the morning, and we spend them on different activities throughout the day, right? So making a meal, or having a shower, or getting out of bed, going some specific place, talking on the phone. All of these things spend our energy, or spend our spoons. And when we've had a concussion injury, what people will describe is that it feels like I have less spoons when I start, and the cost of doing things becomes much more profound, that I spend more spoons when I do things. And I feel like I just, I'm running out by the end of the day. I don't have the appropriate amount of spoons that I had before. And I feel like I'm not sure where to get more. And part of our goal in this conversation is to start to reflect and think on that. So what about that recovery process? So a lot of literature and research has gone into this, and I think it's one of the most commonly described experiences is that the more that a person does, the more they feel, whether it's physical or mental, they feel that my symptoms intensify, right? So if I really push myself cognitively, if I really push myself physically, they see this increasing of symptoms. And that becomes really challenging because within that sort of process of feeling like I sometimes have to do things, like I have to go to work, I have to, take care of my child, for example, or tend to the family or navigate some personal responsibilities, don't have time always to listen to what my system says. And so it becomes a real balancing act around navigating, how do I listen to my system and not push through, right? There are many places in life where pushing through has utility. So sometimes, for example, when we're feeling anxious, one of the best things we can do is actually try the thing that's making us anxious. In this situation, concussion injuries, listening to our body, 9 times out of 10, is going to produce better results than pushing through. And the challenge is our life doesn't always permit that. And so really connecting with your healthcare team, particularly if you find them supportive around how do I navigate this? Like if I feel like I don't know how, can I reach out to, my family doctor and I know a number of family doctors in the region who are just incredibly informed about this. Not every family doctor is, but some definitely are. And thinking about that first 3 month, 1 to 3 month sort of period of time, can we start to think about gradually increasing exertion? And our goal is not to push one past that sort of point of no return where it's like I feel like if I go into that red zone, I dig really deep, I'm out for days kind of experience. It just really exacerbates all of my symptoms. And so we want to listen to that piece and we want to as carefully as we can stay underneath that threshold, right? So we call that sub threshold exertion. And we want to utilize breaks and modify kind of our environment as best we can. And that's why you'll see some people who there's certain grocery stores, for example, who very kindly will dim the lights or turn the music down at certain periods of time, and that's the time in which it might be best to go grocery shopping. And so navigating that, or you might, for example, wear sunglasses and try to modify the environment when possible. So there are many approaches that people have come up, and I've been incredibly impressed by some of the creativity that clients have demonstrated in trying to navigate some of these different challenges. And so the goal is to gradually kind of return to some of our activities of, sort of interest and passion and some of our responsibility. Obviously, one thing we do know is that if something I enjoy doing is likely going to give you some spoons back in addition to taking some, whereas things that are harder to do, not of interest, are going to require much more kind of executive, frontal contributions to our behavior. And so it's going to be more costly to us. And so you may find that certain activities are more costly than others, right? And so our goal is really just doing this very gradual, gentle sort of increasing of exertion, both physically and cognitively, and staying underneath that threshold. We don't want to be into the red zone because that will often set us back in our progress. We do know that approximately, and there's debate on this exact number. We do know that 85-ish% do have sort of a full functional recovery. But there's certainly many individuals that describe much longer symptoms, and there's a whole host of reasons for why that might be. There are some, for example, predictors of that recovery process. Some of them are things like age. So is this a developing brain? Thinking about children, for example, sometimes children will have more challenges in recovery. Sometimes they can have things like what are called silent or sleeper effects, where we don't notice a symptom or experience at first, and it's not till certain brain systems come on later on that say, okay, there's a challenge, right? So for example, in younger children who sustain concussions, sometimes an injury to the front part of our brain doesn't show up till adolescence. And so those types of things can predict sort of unique experiences. The same being with individuals that are elderly. So we'll talk a little bit later about the recovery sort of process and pathway for individuals who are older. Their brains are different. Our brains are always changing. And as we get older, the system is, pruning and being incredibly efficient, but also meaning that there's less neurons to kind of take over should there be challenges in any specific domain. One thing that also has been quite predictive is one sort of, they either their sort of gender or sex specifically is focused on like what is kind of their, how do they reflect? And this clearly is around neck strength, not actually about kind of their specific sex in general. So what we've realized is that the stronger one's neck is, the more capable it is of tolerating sort of the forces applied to the head and brain. And so we do see that on average that women will experience longer symptoms. And that was a real mystery in the literature for quite some time. Why would that be the case? And certainly, understanding kind of the biomechanics of that began to give us some clarity around it. The other piece will be around, previous head injury. So if this is not one's first head injury, then certainly this is going to be, the more head injuries we sustain, the harder it is to kind of recover from that process. So there clearly is a difference between one's first injury and one's 10th injury. Does a person already have things that are taxing their brain in other ways? So for example, experiencing anxiety or depression pre-injury means that a person is already navigating things, and then to have disruption on top of that is going to have different effects. Same with things like history of migraine headaches, and sleep is particularly important. We're going to talk about that in more detail. So symptoms certainly persist longer than 3 months. And, this has been a growing change in our field where we used to think that, there was a time where people thought symptoms only lasted 7 days, and anyone on the 8th day was just lying about it. And that, was never true. And clearly, the research was quite behind for quite some time. But I do think it is much more aware, and much more work has been working on this. And so there's no doubt that symptoms persist longer than 3 months for many individuals. And it becomes really important to kind of partner with, or build a team to kind of help out and navigate some of these symptoms if they're persisting. Some of the things we're going to talk about is thinking about how one can do assessment. There are many different types of assessment that can assist. But one type of assessment is focused on trying to measure many of the challenges that would be happening. So that, in a physical sense, might be looking at things like physiotherapists will sometimes do a treadmill sort of test to evaluate when does a person experience symptoms. So how much exertion does that kind of, take in order to kind of exert that. Other times we will take cognitive and emotional measures, for example, to see where are specific types of cognitive and emotional challenges that a person might be experiencing. Sometimes it's often referred to as neuropsychological assessment, the types of assessment that certain psychologists will do. Much of the goal around assessment is about trying to figure out the best approach to put structured rehabilitation in. And I'm going to talk a little bit about some of the main principles that we use in rehab, so that you know what they are and that you're not having to wait to see someone or share this with a family member. You don't have to wait to kind of see the medical system to get access to some of this knowledge. One of the things we'll talk about is how one might go about pacing, and the other piece is about thinking about maximizing one's deep sleep, which becomes incredibly important. Other places that we focus in is navigating using psychotherapy, because many times one can know what to do after a concussion injury, but implementation in one's life is not as easy as it is to say. So just because you know that I want to go about my recovery process in this specific way doesn't mean that life is letting you do that. So whether it's family or friends or work or school, many things get in the way. And how do I navigate that? And a lot of psychotherapy in the context of, concussion injuries are about trying to navigate, kind of an imperfect system and try to still implement our recovery process. Pharmacology is frustratingly less helpful than we would like. So we don't have very good medications to assist in this domain. Much of our sort of, work in the pharmacology perspective has very much been about symptom management rather than focused on promotion of recovery and making neuronal systems recover better. And so much of the time we try not to disturb the brain because we know that medications have quite significant effects, and some of them intended and some of them not. And so we try to avoid medications when possible. But of course, there are times where we need to intervene because symptoms are just that intense that they're getting in the way of other things we're hoping to carry out. It's important to know that even though some people will experience, concussion symptoms after 3 months, that the brain is recovering by itself, even if you did nothing, upwards of at least a year, and some evidence to say that that process may extend beyond that. But what we do see is a change in the speed of recovery at that sort of approximate 1 year time period. And so we do know that we can certainly put in strategies that can help and work on building the system up, quite lengthy. I know that in our research lab, we were able to demonstrate that even 10 and 15 years post-injury, that recovery could, improvements could be observed, even in injuries that people have said, well, this is not a person that, can see any more improvements. And so I don't believe there is a limit to this, but it's clear that the further away we are from injury, sort of the more work we're putting in to kind of get some of those gains. And certainly, putting some of that recovery process in that first year is of particular utility. So it's certainly a bit easier or more helpful to kind of put some of the recovery in. And the challenge is that our system is not very quick to react because, often it's hard to see specialists quickly. It's hard to get into the right appointments and learn some of this information. So you can see the frustration that understandably many people experience when knowing that I want to work on this. I know I need to, but the people I want to see are not super available. So let's talk about one of the principles of navigating this recovery process. So one of the most key concepts I think is something that, I certainly talk about probably every single day in my practice is thinking about strategically how to pace ourselves. And pacing really is about being systematic and trying to figure out, how do I use the spoons I have in the most effective fashion, and how do I use that energy, and can I start to really listen to my body appropriately and effectively. And so when we don't do this, what we experience is this idea of what's called boom and bust. So we do a lot. Particularly, I think the hardest experiences for people that I've met and worked with has been about the good days. The bad days seem to be easier to pace on, but the good days are sort of seductive in the way that they affect us, is that it's like, finally, I have been waiting for a good day. I'm going to do as much as I possibly can because I'm so behind. I need to get all on this, and I tend to overdo it. I don't listen to my system, and then I pay for it dearly. And unfortunately, what happens for a lot of people is this sort of effect of, increasing my activity, plummeting as a result of the, difficult symptoms I experience, and then having to kind of push back up. And unfortunately, the trajectory, when you map it, actually often is mapping either staying the same, or more times than not is actually declining. So I'm actually losing some of my kind of endurance and stamina as a result of this sort of boom and bust. So it's equivalent to, for example, going for a run, running as far as you possibly can, injuring yourself, and then having to take time off. And the moment that you get somewhat recovered, you do it again. And how do we really expect, or do we predict that our length of running is going to increase or decrease? And what's clear is, unfortunately, the direction is not where we want to go. And so what can be very frustrating but incredibly necessary is this idea of trying to pace ourselves, where you would do a bit and then be able to self-monitor and check in with your system from time to time to detect, hey, when should I be trying to stop? And this is very hard because, of course, it depends on the context in the situation, but trying to best predict, when am I just sort of inching up towards that threshold, and let's stop there. And that's hard to do. It's very easy to say, but hard to implement, and then rest and recover and then go at it again. And this seems to be the most effective way of building endurance and building capacity. And we can take someone, that's been feeling like I can't navigate life at all, and slowly build up into very complex forms of behavior, very, much more endurance than anyone expected them to be able to get to. But it is time consuming. Takes, patience, and understandably, life has changed sometimes for many people after these injuries quite significantly. And so it's incredibly hard to carry this out. So I do think that knowing this becomes incredibly powerful to motivate ourselves and see the big picture. Because when you're riding kind of the boom and bust, it feels like, in the context, I can't see the big picture. But the big picture here is about how I can make these systematic changes to listen to my body more, and to be more effective at sort of stopping when I need to, and then practicing and engaging again. And most people struggle the most with the stopping, not necessarily kind of the doing. There's a lot of eagerness to kind of, I want to get back, I want to feel myself again. And it's hard not to kind of feel like I just want to go on the good days. So when we start thinking about maximizing sleep hygiene, there's lots of incredible research that's been done on this area. But the key elements is understanding sleep at first. So sleep is actually much more complicated than it looks. So we want to sort of optimize our sleep, because we know that only when the neurons slow down enough can they recover and sort of rebuild chemistry, patch up sort of, the structures of the cells. And so understanding how sleep, what effects it has on the brain is very important. So in wakefulness, when we put EEGs, sort of measures on the scalp, so we measure, the brain at the level of the scalp, we can see that cells are doing all sorts of different things. Some of them are organized around, say, vision. Some of them are organized around language. Some of them are going to do executive function. All of them have different purposes. They're all communicating at different rates. And when you measure it, you essentially get sort of this, low, high frequency, low amplitude signal here at the top. So wakefulness. And you can see they're tiny little waves that represent not huge electrical changes. And what we know about sleep is the sort of deeper the sleep, the more the system is synchronized, right? So the more that neurons are firing at the same time and then not firing. And it produces these very sort of deep, large amplitude sort of waves, when we measure the electricity of this. And so what's really interesting is that sort of deep sleep, that opportunity to kind of like, get the system synchronized, is the time in which it's going to recover the most. And so getting optimal deep sleep becomes absolutely fundamental to recovery processes. So we need to promote that. We need to optimize that. And that's not always easy to do. So the brain, because deep sleep is actually, in terms of our evolutionary history, dangerous. So for example, if I'm sleeping outdoors and an animal comes, deep sleep is when I'm most vulnerable, right? I'm going to miss the sounds and the indicators. And so in order to sort of protect ourselves, our system has built sort of these 90-minute cycles where essentially we go into sort of lighter stages of sleep, then into deeper stages of sleep, and we pop back up into REM, which almost looks similar to wakefulness. And REM has some incredible effects on cognition. We know that it's very important for things like learning and memory. And so one thing that becomes really important is, how do we get our sleep, into deep sleep the most effectively? How can we maintain that as best as one can? And so really thinking about making sleep predictable for the brain, optimizing the environment. So, there's clear evidence on things like temperature change being important. So just before sleep, having quite a significant temperature change. So many people, for example, can achieve this through something like a hot bath and then getting into a cool room for sleep. And that temperature change really seems to, set our system up for optimizing sleep. The brain needs to predict when sleep is going to happen. And so if our sleep schedule is inconsistent, usually for very good reasons, it becomes a lot harder for the system to predict. And the extreme example would be things like shift work. So if a person, some days is on days and then sometimes on nights, the brain says, I have absolutely no clue when we're going to predict this. And so there's a whole bunch of biorhythms that are not then matching when we should sleep, right? Is the stress cortisol system matching our sleep? Is the melatonin system, is the other neurohormonal systems matching? We want these things to line up in order to have effective deep sleep and optimize it. And so predictability becomes really important. And can we give the brain a bit of warning signs of sleep? So that's why you may frustratingly hear sometimes that maybe a therapist or family doctor will talk about sleep hygiene. And what they're really trying to share is, can I set up predictor indicators? So these ways of telling the brain, hey, we're going to go to sleep, please start preparing, right? So it's like getting into the same exact routine before you go to sleep really does help the system prepare for that, right? And we do know that tracking sleep is effective and helpful. So, whether it's using devices or even, sleep tracking, all of these things have, quite significant utility. And so really focusing on, there's lots of great strategies. One of the most high yield strategies is going to come from not staying in bed when you can't sleep. And a lot of us, when we can't sleep, are so tired, but we can't feel like we can get out of bed. And the challenge is that brains are always learning. And so if they learn that bed is not where you necessarily sleep, it's where you do a lot of reflection or thinking, then it's hard to sleep at that point. When we think about persistent post-concussive syndrome, I had a supervisor in my graduate training that had a great analogy for it. And she talked a lot about this idea that we can think about these things as, when one bridge is out, we can think about how we can tap into other bridges, right? So there are many neuronal pathways. There's a lot of overlap, even in function. But sometimes the most efficient bridge may be the one that's impacted from the injury. And sometimes we have to come up with bridges that are further down the river, and are certainly not convenient to carry things out, but to carry out the same or similar cognitive or emotional skill sets. And we see this more often in persistent symptoms. So sometimes we can't repair all of the bridges. Sometimes we can. And for folks that are living with persistent post-concussive symptoms, so that is that the symptoms are longer than 3 months, there may be some bridges that are not necessarily going to recover in the way that they were before. Even if they do, we may notice differences in it, right? And being able to work with that, acknowledge that, and then find the other bridges becomes the key to it. So, I had one other supervisor say the idea of building a new kind of user's manual around, I've got this brain, I've grown up with it, I've gotten to know it so well, and overnight it feels like everything has changed. And they had a wonderful analogy about figuring out, like, well, let's build a new user's manual. Like, you had a manual that you had built and it was fantastic, but now it's time to make some modifications to that manual because the system is different. And the reality is that our system is always changing. What makes concussion or any kind of acquired brain injury difficult is the fact that the suddenness of the change, gradual changes we can adjust to, but the sudden shock of that change, right, and this sort of intensity of that change all at once is incredibly challenging to navigate. And if you haven't had an injury, it's sometimes hard to really appreciate the effects that it has on someone that has. So working with the specialists in this area really does help to kind of delineate what symptoms are likely to be permanent. And so when we work on symptoms that are permanent, we start shifting gears from retraining, sometimes called remediation strategies, to more compensatory strategies. So let's find another system that does similar sorts of skill sets and see if we can recruit that one to carry this out. No, it's not as convenient. Maybe it's not as efficient, but we want to be able to carry out what you wanted to carry out, your goals, your interests. We do know that certain brain systems are more vulnerable to injury. So we're more likely to see certain types of cognitive and emotional, physical effects because certain systems are more vulnerable. And that means that they're more likely to be disrupted. That doesn't mean that every injury is the same. It just means that these systems are the ones that we most frequently see. And so I've given you some very interesting, colorful pictures, but essentially what these represent is systems that are involved in quite complex forms of thinking. So things like how fast we can process information, sometimes called processing speed, or being emotionally informed about a context. And we can talk a little bit about some of the specifics around some of these experiences. One thing that has really helped to inform us around this is this idea that how much emotional and cognitive arousal a person has at any given time also kind of predicts and contributes to their performance at any given time. So if I'm trying to give it this presentation and I've just gotten out of bed and I'm super exhausted and tired, you're not going to get my best cognition, right? Versus if I'm having some stage fright and feeling extremely anxious about something, I'm also not going to display my best cognition. And so we call this an inverted U. So this curve represents our relationship between arousal on the x-axis and performance, our ability to output cognition on the y. And what we're trying to aim for at any given time is, if you're in the zone, you're in this sort of optimal state. And what we know from the research in our lab, but other labs have looked at this, is that individuals appear to be autonomically dampened. And so what that means is that the system is less aroused. And so essentially this is proportion to injury. So it means that, mild injuries have less, their arousal is less dampened. And so individuals with more severe injuries seem to have more problems in this domain. And this makes it then harder to be kind of emotionally informed in that context. And we'll talk about the cognitive and emotional effects that this dampening tends to have. But an analogy that our research group tended to use was this idea of walking, in a dark alleyway, and this idea of you may cognitively know, like, hey, like this is a bit sketchy and creepy, and I'm not keen on it. And emotionally, your system begins to prepare and it starts to rev up, and you're just feeling on edge. You're kind of vibrating in that regard. And for individuals, sometimes without, they've sustained an injury, they cognitively are knowing, hey, this is not the safest, easiest thing to do, but emotionally, their system is not kind of revving up. And so when something kind of startling or surprising happens, it goes from this, far left side to the right, all of a sudden we get this huge reaction, right? So much more emotion than I anticipated, much more this sort of startle response that can happen. And sometimes it's, led some individuals post-injury to be labeled with things like aggression. And it's not the case that people post-injury are more aggressive. It is the case that they can be more startled and they don't anticipate some of the outcomes that can happen. And our research group, as many groups, have looked at different sort of areas in terms of cognition. So I'm going to talk about a couple of them. So things like how fast one you can think, how much information can you have at any given moment. We'll talk a little bit about some of the effects around this. I want to talk about attentions first because I think it really makes sense. I think it's one of the most commonly described challenges. And it's important to know that attention, it's actually made up of many skills. It's not just, what we kind of think about and what we hear. It really is about our ability to kind of focus, really kind of narrow down. And the best sort of analogy I like to think about it is like a spotlight that we can sort of move around. So we can kind of like move the spotlight all around, and it's separate from our visual or auditory system. You can actually be, visually sort of linear, but then move your attention around. And that's important to kind of keep in mind. And then we can also kind of like narrow this attention down. So we can actually like force it down. And the challenge with concussion injuries is this ability to regulate our attentional resources. And what many people will experience and describe is, I feel like I start off okay, and then over time, the more I use it, the harder it gets. And I feel like I kind of run out of energy in the tank or spoons at that point. And it has a lot to do. So the way that our brain carries out the spotlight is this coordination between the front part and the back part of our brain. Because in neuroscience, we have to sound fancy. We call this the frontal parietal network. So the front part of the brain, frontal network, and then the parietal network. And so we put them together. We're not very creative in our field, but and we describe that as the sort of linking between these two systems. And so the more that you use your attention, the stronger this network becomes. The front part of the brain keeps in mind your kind of goals and your intention, what you want to kind of focus on. And the back part of your brain says, where in space is this? And so the talking between these two networks is what coordinates our attention. And it's clear that this system is more rapidly exhausted post-injury for many individuals. And that it's also clear that we can train this. It takes lots of practice and hard work. So sometimes we use attention-based training. Some people really enjoy kind of forms of meditation and mindfulness as another form of attention training. But it's clear that this system changes with practice. So it, just like a muscle, it actually seems to grow. We can measure that growth on our brain scans pre and post injury in the research context. So we know we can change this. But it is true that many people will describe, hey, like the more I use this at any given specific moment, I feel like over time, my attention just isn't as good and I need to take a break. And so that pacing principle becomes very important in terms of growing this network and making this network stronger. When we think about working memory, I think the best analogy I've heard for it is about thinking about, it is a desk that you can kind of put things on and kind of process information. And it's really important for being able to think in the moment. And so this idea of like, it's very much paired with how fast one can think. So we call that processing speed. And the two of these things, working memory, the size of our desk, so how much you can put on it, it doesn't stay there forever. It's just a temporary thing. The larger your desk, the more information you can put on it. And then your speed of thinking also, puts together how much we can think in this moment. And I think a lot of people after concussions feel like their intelligence has changed. Like, I don't feel as smart as I was before. And it's not true. In fact, we measure it all the time, and we don't see intelligence changing. What we see is the expression of one's intelligence is harder to display. So the person is equally as smart as they've ever been, but they can't get it out. They can't feel like I can't find the words. I can't hold the information. I can't think as quickly as I could. And that's where they sort of struggle. And so a lot of our strategies are around how can we change things? If working memory is hard for one, how do we come up with strategies to maybe not hold all the information in mind at the same time? Can we, pull out the whiteboard? Can we, write down all the variables? Can we slow this down so that I'm not trying to hold it on my desk and then problem solve at the same time? That's a lot to require the brain to do. Can we come up with creative strategies around that? Same with things like cognitive flexibility. So cognitive flexibility is that ability to change from one direction in a task to another, change from one type of thinking to another. And so I love these sort of pictures that show two ways of thinking. So on the right hand, two ways of seeing these pictures. So on the right side of this image, you can see this person either looking straight at you or seeing them from a side view, and versus seeing these what look like people versus these vases here, right? So these show us that you can, those that can switch back and forth, you're utilizing some of this cognitive flexibility. And cognitive flexibility is incredibly important for being able to multitask. So being able to, feel like I can, go from one thing to another. And often we're so good at switching between two things that we almost look like we're doing two things at once. And we call that multitasking. But really, it's more about how flexible you are. So I always think about this analogy of, a person with their child in the, grocery store. If you notice, they may be carrying out two things at what look like at the same time, but at one point they're tending to their child, and then another point they're looking for a vegetable. And they're doing that switching back so fast, it almost looks like they're doing two things at once. And the reality is they are just doing one thing at once and switching between two sets of behavior very quickly. So cognitive flexibility is a place that many individuals after an injury describe as much more difficult, and is a place that we can build strategies around. So how can we promote our flexibility? And one of those best strategies is about talking to yourself while you're doing it, right? So we can I'm going to be flexible. I'm going to switch if I feel that I get stuck in a specific way of thinking. And if I can know that, that's amazing. Not always is that easy. Or can people in my life help me kind of know that? Can I talk myself through making that switch? Sometimes that can help us be that. And sometimes we have to change how we do things, because maybe it's not easy to kind of like make those switches so rapidly. And can we lessen the demands, at least at first, and slowly kind of build them up? We know that this has a lot of neurological processes, and they're mostly in the front part of the brain. The cool thing to think about is that this is like a conductor that organizes the brain and says, no, you slow down over there and you start up over there, right? And that coordination is what is the product of cognitive flexibility. So the last kind of area I'm going to talk about is around mental health and concussion. One thing that's become clear is that many people experience symptoms after concussion, and one particular area is around depression. One of the places that I spent a lot of my own time in research was trying to figure out, is this depression the same as a person that's experiencing depression before their injury or never had an injury? And we do see this relationship between concussion and depression. And for some reason, the treatments don't seem to work as well. So it really kind of raises this question of where is the challenge? And so one thing that came out of some of the work that we did at Brock was looking at the idea that people experience their depression differently. So we can experience our depression in our body, in our emotions, or in our thoughts. And one thing that became clear is that for most people that haven't had an injury, they experience at least part of their depression in terms of kind of sadness and despair and feeling this negative emotion. And many folks after concussion injuries seem to experience their depression in terms of their body kind of feeling dampened. And so these somatic symptoms seem to be the hardest place for them. They were feeling lots of incredible fatigue and kind of lethargy and just not very difficult to get going, and lots of different body sensations, this dampening, lots of things like apathy rather than sadness. And it turns out, as I researched this, that this finding had been found in stroke like 20 years prior, but hadn't really been acknowledged. And so we did explore, well, what can we do about this? And it turns out that looking for things like activating the system, like, optimizing exercise, optimizing sleep. And when we're going to use pharmacology, rather than just focusing on medications that increase serotonin, we needed to think about medications that affect dopamine. So whether that's antidepressants that affect dopamine in addition to serotonin, or looking at medications that affect dopamine exclusively. And some of those medications come from the treatment classes that are used in ADHD, so psychostimulant medications, for example. The other piece that one of my colleagues in the lab looked at was focused on anxiety. And anxiety after, concussion is a common experience. And one thing that they found was that if we go back to that dark analogy of the, analogy of going through the dark, alleyway and, feeling surprised, after my injury, and I was startled because I didn't emotionally expect something to kind of startle me. What if that's happening kind of often? And one thing that became very clear as we started to take anxiety apart is that the anxiety is much more reactive anxiety rather than anticipatory anxiety. So I'm anticipating that, this is going to be hard and challenging. It's much more that the world feels so chaotic and hard to predict that I'm reacting. It just feels like there's fires everywhere and I can't see them coming. Even when cognitively I know they're there, emotionally my system is not anticipating them. And so we really learned that this anxiety experiences are quite different. So are there permanent effects of concussion? The simple answer is physiologically, yes, but behaviorally and cognitively, it depends on who you ask and how we measure it. Most people will have, large majority of people with concussion, they will get to a point where they feel like I'm back where I felt like I was. But we do find, even in people who are asymptomatic, so we studied this in university populations at some points and found that even asymptomatic people, if we measured them intensely enough, we can see that there are subtle, not impacting their function, cognitive and emotional changes. And so one question I always think about is this person having to use their brain to the maximum of their capacity? If you have to like tax your brain to the limits, often as your line of work, or your interests or your passions, you may notice it, for example, more than a person who doesn't feel like they have to tax their system as often. So if your lifestyle, your area of interest is not taxing that system at its limit, you may not notice it, but there may be changes to that system. And it's important for us to think about that when we're thinking about treatment strategies. And we have to be cautious not to dismiss people around that. Are there other factors that then interact with that? So for example, sometimes things like substances or mental health challenges that were happening beforehand are also happening afterwards. And if they're impacting the same neural processes, of course, that's going to be harder, right? So these interaction effects that I've kind of talked about. So the answer to this question is that yes, there are differences. Will we always notice the effects? Not necessarily. It really depends on the context. It depends on the injury. It depends on what the person's requiring of their brain. But the reality is the brain is affected by everything. And so it's not surprising that it would also be affected by concussion. We know that multiple concussions are associated with greater challenges. This is very clear. And we know that with respect to like athletes, one concussion significantly increases the risk for another concussion, particularly within that kind of first 10-day period. And we do have concerns. You may have heard of Rowan's law that really speaks to this second impact syndrome, that having multiple concussions in a short period of time can actually result in, fatal sort of impacts. And subconcussion effects are also quite significant. So they can be related to, symptoms that are very similar to concussions. And we look at things like, athlete populations that have repeated concussions over and over. And we can measure this, even in athletes that we're not looking at concussions. So one season of, college level football is associated with, significant, measurable change in fMRI on white matter. So the connections that do with the speed of our thinking. One question I get, and I want to be reassuring around this, is if I've had a concussion, will I get dementia? And the answer is complicated. So if the person has sustained repeated high frequency hits, like some of our professional athletes have done, there is some evidence to say that there is a link to chronic traumatic encephalopathy, this type of dementia process that's described in the concussion movie. And for individuals who experience single or even multiple concussion events, I don't want to say that there's no risk, but the increased risk does not surpass other sort of known risk factors. So things like dietary and physical fitness levels that certainly do predict things like dementia processes. And we know that we have to take precautions. We do need to limit our injury exposure, particularly if you've sustained an injury already. But I do want to draw attention to the idea that age matters. And if you sustain your injury later in life, that it can lead to more challenges, right? So we can look at some of this work recently done, looking at severe traumatic brain injury resulting. Some individuals recover, some of them, will have recovery, but then start to sort of experience decline. And we do know that the more injuries a person sustains, particularly as they're getting older, seems to have some linkages to dementia, and particularly with respect to Alzheimer's disease. So it's clear that having our injuries later in life have greater costs. And so the older we get, the more important it is to, really work on limiting our exposure to injuries, working on fall prevention, working on balance training, working on, maintaining physical cardiovascular capacity and physical strength. So should symptoms persist, I want you to know that rehab is always possible, and it's important to find the right professionals to kind of assist you on this journey. Pacing, as you can see, is clearly important. We have to optimize our sleep, and don't be afraid to kind of alter our environment. Seek out, support clinically when you need it to find the best rehab strategies. This becomes so important. So our take-home messages, I'm sure that everyone's feeling like, okay, I'm exhausted by this process. What can I take away from this? So know that while many people recover from concussions after, within 3 months, some will continue to experience symptoms longer. And education is key to really building our knowledge. The more that you learn about concussion, the more capable and more systematic in your approaches and how you navigate this. And I want you to leave this presentation feeling a lot of hope that even if you've had symptoms, or someone who's had symptoms for a great deal length of time, there's always things that we can do around this. So I want to take a little time here to then, take a little breather, to rest and relax. We can stop the recording. If anyone needs to step away for a little bit, and take a breather, and then we can come back and talk about some questions if anyone has any.